Okay, we will make a start. Well, good afternoon, everyone, and welcome to teaching today. Firstly, I want to say that I hope you can hear the sound okay, because last week, I think those who are online could hear the sound, but in the recording, it wasn't very good. In fact, the sound was very muffled, and what's uploaded on YouTube is not interpretable. So I'll at some stage record that lecture again. It was about neurodevelopmental problems. So I'll record that again and upload it. But today, so thanks for those who informed me about that. Today I wanted to talk about septic shock. It's a surprisingly common problem, and I think it's under-recognized. And we often recognize the underlying infection, that is pneumonia or malaria or some other infection, but we miss the fact that a child's got severe systemic sepsis or septic shock. And I want to try to talk about that today. There's a lot one could say about septic shock regarding pathophysiology and that sort of thing. I'm going to very briefly touch on that, but most of what I'm going to talk about today is about the recognition and the early management of septic shock, because I think we, could be doing that somewhat better. But I will touch on what septic shock is and say how there's a large spectrum between just the inflammation that a patient has when they have an infection, a normal, helpful inflammatory response, and the disordered or dysregulated inflammatory response that patients have if they've got septic shock or severe systemic sepsis. And all these things that indicate a patient's got inflammation or infection, such as fever or the white cell count going high, leukocytosis, or inflammation at the site, whether it's redness or an influx of inflammatory cells at the site, or the warmth that you feel at the site of an abscess. They're all adaptive inflammation. They're positive, they're useful, they're required, they're necessary for the control of an infection. And even before we had antibiotics, many infections would clear up by themselves because of the body's ability to fight an infection with the normal, regulated, coordinated immune response. But as I said, that's a regulated immune response. And septic shock is where you've got dysregulation of the inflammatory response, or where you've got where the underlying infection is not being adequately treated and you get overwhelming of the inflammatory response. So for two reasons: one, a dysregulation of the inflammatory response, or two, because the patient hasn't received the right antibiotics or any antibiotics at all, or because they haven't had adequate source control of the infection, then they have an overwhelming inflammation related to the bacteria proliferating, usually bacteria, but not always. And the sorts of dysregulation of the immune response include what's called cytokines. Cytokines are enzymes that are released by white cells, and they cause what we call vasoplegia, which is like the blood vessels become very dilated, and that's why the blood pressure drops and the capillaries of the blood vessels become very leaky. They're two main things that happen to the circulation when a child or a patient has septic shock. At a microcirculatory level, like at the level of individual organs and cells, usually then, because of that vasodilatation, there's not the same adequate blood flow to organs, and you get tissue ischemia or hypoxia to tissues. And because of this vasoplegia and the hypotension that goes along with septic shock, then there's reduced oxygen delivery to tissues, and there's often impaired oxygen use at a cellular level. The cells can't use oxygen very well. The mitochondria are somehow poisoned by the septic shock, but also there's not enough oxygen being delivered to tissues because there's not enough blood flow to tissues, because there's vasoplegia or there's capillary leak, and all the blood, the fluid, like not blood, but the plasma is leaking out of the tissues. So all of those things happen in a mild or moderate or severe degree, depending on the type of shock or type of sepsis that a patient has. All these things are, when you see a child who's got like cellulitis or a localized abscess, those things are happening at a local level. But it's when it happens on a total body level that the patient has septic shock. And there's a wide spectrum. And septic shock can, I think, creep up on a patient fairly gradually over hours or days if their infection is not adequately treated. And that all leads to organ dysfunction and organ failure. So the organs that can fail, we often think about heart failure or whatever, but there's other organs that can fail too. You can get kidney failure, an acute kidney injury, or the liver can become very dysfunctional and fail. But the gastrointestinal tract can fail and you get ischemia of the gastrointestinal tract. The heart can fail, the lungs can fail. All of these, it can affect all the organs, even down to, say, the muscles, and the muscles start breaking down. So there is an inflammatory response that can affect all the organs of the body in septic shock. And as I say, often we see children relatively early in the phase of sepsis, but if not adequately treated, then they will get septic shock. And the good thing about it is if you can start to identify patients who might have septic shock, more than just a localized infection, but might have a systemic infection, if you start to recognize those patients earlier, then they can get adequate treatment. Septic shock has the highest case fatality rate we record, as you know, over 30 diagnoses for children in Papua New Guinea through the pediatric hospital reporting system. And every year, year after year, septic shock has the highest case fatality rate. So even more than 50% in all hospitals, but in some settings, it can be up to 70% mortality rate for septic shock, as you probably know. Septic shock is often associated with infection in some other site, like it could be pneumonia or complicated pneumonia where a child has an empyema, or a urinary tract infection where they get a systemic infection, pyelonephritis, or a gastrointestinal tract infection, and especially in malnourished children, or meningitis. All of those localized infections can be associated with severe systemic infection. And it's recognizing when an infection's gone from just a localized infection to something more systemic. That's what defines a patient having septic shock or severe systemic sepsis. And the early recognition of such patients and the early treatment of such patients is really vital. And that's what saves lives, the early recognition and treatment of early septic shock. If you wait until the patient's got very established septic shock with severe hypotension or established shock, then that's when their mortality is 50 or 70% risk of mortality. I just wanted to show you this short video of a small girl who had quite severe pneumonia. This was a 3-year-old girl, but you can see, I just want you to watch her, and you can see a few things. One, if you look at her oxygen saturation, you can see her saturation is 63 and her heart rate is 147. So that's fast. It's not very marked tachycardia, but it's tachycardia nonetheless. But I want you to look at, I'm going to show it again to you because I want you to look at some other features of this child. And I particularly want you to think about her airway, breathing, circulation, and her conscious level. I guess the first thing to say is that her airway doesn't look too impaired, does it? Her airway seems to be okay. You can't hear any stridor. There's no particularly obstructed breathing, but she is poorly conscious, so her airway is likely to be at risk. I want you to watch her breathing now. I'm going to show it to you again. I want you to watch her breathing. She's got fast breathing, hasn't she? She's got fast breathing and she's got a degree of chest indrawing, but it's not very severe. She's got moderate chest indrawing. And if you were just to walk past her, you might say, well, she seems to be breathing fast, but maybe reasonably comfortably. Now, a child who's got a saturation level of 63 or 62 really should be breathing much more than that. They should be breathing with more respiratory distress than that. So what it should prompt you is to think, is this child breathing adequately for the degree of desaturation they have? And in fact, this girl's not breathing adequately for the amount of desaturation that she's got and the severity of her pneumonia. Her respiratory distress should be more. And then you've got to ask yourself, well, why is she not breathing adequately? And it's because she's got severe septic shock. Now, so circulation is, we can see that her heart rate is 148, so she's got tachycardia. But I want you to look at her now, we'll talk about the other aspects of circulation, which you can't tell from a video. You have to touch the patient. But I want you to look at her conscious level and just make some observations about that. Now, she's 3 years old and she should be really alert and she should be interactive. And even if she had severe respiratory distress, she should be more awake and aware of her surroundings. But she looks like she's, very sleepy and drowsy, isn't she? She's having trouble keeping her eyes open. And these are all the features of septic shock. They're all the things that you see in a child who's got a more disseminated infection from just a localized pneumonia. I'll just show you her X-ray because I think it's important. This is her X-ray, and if you looked at this X-ray, you'd say, well, she's got a severe pneumonia. She's got severe patchy changes in both lung fields. These opacities, almost round-like opacities in both lung fields, quite extensive, you would say bilateral bronchopneumonia. But clearly she's got more than that. If she just had bilateral bronchopneumonia and she didn't have systemic sepsis, then she would still be alert. She would be breathing faster. She would still be just as hypoxic, but she would be in more respiratory distress probably, but not be as, her conscious state would not be as impaired. And I think it's her severe impairment of conscious state that indicates that she's got severe septic shock. It's another child I just wanted to show you who also has some rather similar characteristics. I mean, he's got tachypnea and he's grunting, and you can see the rash that he's got, which is quite a severe purpuric rash. But look at his conscious state. He's really poorly conscious. And this is a child who's got very severe septic shock. And we often see such patients that say, well, they probably got meningitis. Well, they might have meningitis, or it just might be severe septic shock where he's got inadequate, oxygenation and blood flow to his brain and the rest of his body with severe septic shock. This is another child I wanted to show you just also who had, this boy was a 10-year-old boy who had 24 hours of fever, lethargy and vomiting. That was his presenting complaint, 24 hours of fever, lethargy and vomiting. And you can see that he looks pale. He's not very responsive to his environment. He's a 10-year-old boy, so he should be awake and interactive and alert, but he's very poorly conscious and his lips look quite dry. He's got these small lesions on his lips. He's got the same problem as the previous child I showed you. He's got severe septic shock. I'll just show you this is his breathing. He's got also tachypnea. And he looks very pale, doesn't he? Huh? This is his foot. Obviously, his feet would feel very cold and his capillary return would be very prolonged. And he's got a non-blanching rash in several parts of his body, in several parts of his skin, a non-blanching rash. So this boy's got meningococcal septic shock, as did the previous boy who had meningococcal septic shock. And the previous girl that I showed you had staphylococcal septic shock. And so you can see the same manifestations of severe systemic infection where the conscious level of the patient is severely affected. Now, occasionally you see children with septic shock who are normally alert and normally conscious, but they have other signs, respiratory signs, cardiovascular signs, skin signs, etc., a rash. But mostly they have an impairment of conscious level. So I just want you to be really alert to that about trying to make the diagnosis of septic shock a bit earlier. This is another child who had septic shock, and there's no video, but you can see that she has severe, like she seems to be severely unconscious. She's got she looks very drowsy. She looks very edematous as well. Her face looks very puffy, and she's got that capillary leak appearance of children who've got severe sepsis or septic shock. This was this girl who just had arrived, and she just had some resuscitation, but you can see that her oxygen level is low, 89%, and her heart rate is high. It was 187, and she just looks edematous and systemically very unwell. Systemically means in all ways over the whole body. The clinical signs of sepsis that we need to look at, I've shown you in the videos and the pictures, but if we're doing triage, then sometimes the airway is under threat because of the child's poor conscious state. But usually, unless it's an airway problem like a retropharyngeal abscess as the cause, then usually the airway is okay. It's really just it's under threat because of the poor conscious state. But patients generally have either severe respiratory distress from their pneumonia or their empyema or their dehydration and shock, or they have an ineffective respiratory effort. And that's even a later stage of septic shock where they have ineffective breathing. They have respiratory depression, or they have grunting, or they have whimpering, just like I showed you in a couple of those videos. The boy in the second video had sort of whimpering respiration, grunting respiration. He wasn't making very good respiratory effort. Their lungs are very much at risk because of the capillary leak and the general inflammation. Then they can have increased lung water and they can get pulmonary edema, and they can have quite poor lung compliance. Their lungs get very stiff. And even if they don't have pneumonia as the underlying source or empyema as their underlying source then of the infection, then they can have very poor lung compliance because of pulmonary edema related to the severe sepsis. If they do have pneumonia, then it can be even worse. In terms of the circulation, children can have two types of septic shock. One is the early stages of very warm septic shock, where you've got a patient who doesn't look pale like the third child I showed you, but they may seem quite warm. They have a temperature of more than 38 or 39, and they have bounding pulses often, but still they'll have a low blood pressure. But their hands and feet may feel warm, but their blood pressure will be low. And then as septic shock advances, the inflammation becomes more dysregulated as they get more systemically unwell and they get more capillary leak and vasoplegia, then their limbs become cold and their capillary refill will be slower, like very prolonged, and their pulses will be more difficult to feel and their blood pressure will be low, and often they have a very narrow pulse pressure. So as you know, the normal pulse pressure, let's say, of a baby who's 12 or 18 months of age should be about 90 on 50 with a pulse pressure of therefore 40. And sometimes when a child has severe septic shock, they'll have a blood pressure of like 70 on 50. So their pulse pressure might only be 20, a very narrow pulse pressure if they have unresuscitated septic shock. So measuring a child's blood pressure is important, and also understanding what their pulse pressure is important. That whether they've got a wide pulse pressure, like in the early stages, a hyperdynamic circulation where they will often have bounding pulses and a wide pulse pressure, or whether they've got a narrow pulse pressure, and it can indicate to you just what you should do in terms of if they've got a narrow pulse pressure, they really need to have some volume expansion to try to improve their cardiac output to begin with. I'll get onto that. And you've seen the signs on the videos of a child with a poor conscious state and septic shock. They're often lethargic. They may be confused. Even in the early stages, they might just be confused, as we often see children who've got typhoid, they're often confused, they're a bit agitated, they may be lethargic, but as they get worse, they become poorly responsive with their eyes, like the child in the third case. They might have roving eye movements. They might not be able to fix and follow and focus on things like the child in the first case. And they may have trouble staying awake, like the first two children, trouble staying awake or trouble focusing on anything. Again, in the early stages, they might just be confused. They might just be not their normal behavior. Sometimes they'll have seizures, and that's because of low blood pressure, so they don't get adequate cerebral perfusion pressure, or they might be hypoxic, like the first child I showed you, or they might have the central nervous system like as a source, like they have meningitis. But you can see how it affects all these different organs. There's other organs it affects as well, but in terms of the triage system, airway, breathing, circulation, conscious level, etc. The common causes of septic shock, I think, are reasonably well known, but it is important that we understand these, because when we start, if you see a child who's got severe systemic sepsis, then you need to start empiric antibiotics that cover all likely pathogens, Don't just say, well, I think this is meningococcal disease, or I think this is one. To make sure you cover, oh, I think this is just pneumonia. Make sure you cover all the likely pathogens. And the four pathogens, four bacteria that cause septic shock most commonly in older children, children over the age of 2 months, are Group A Streptococcus, right, which, as you know, is the Group A strep is the bacteria that can trigger rheumatic heart disease and can trigger post-streptococcal glomerulonephritis, for example, but can also, of course, cause skin infections, and it can cause empyema of the lung, pneumonia and empyema. Streptococcus pneumonia can cause meningitis and can cause pneumonia, and they can spread to cause septic shock. Staph aureus is it causes abscesses in many places, pneumonia, osteomyelitis, etc., but can also often lead to multifocal staphylococcal infection and septic shock. And when you have a child who's got Staph aureus infection, you need to think to yourself, is it MSSA, so methicillin-sensitive Staph aureus, or is it MRSA, methicillin-resistant Staph aureus? Very important to make that distinction. And there's more and more MRSA in the community at the moment, in all communities across the world, but certainly in PNG, there's more MRSA being found. Or do they have Neisseria meningitis? Like I showed you the two patients at the end, the two boys with meningococcal disease, where there's often purpura, a purpuric rash like that. In the first three pathogens, Group A strep and strep pneumonia and Staph aureus, it's a typically erythematous rash, red rash, whereas in Neisseria meningitis, it starts off being red, but then it becomes often typically purple, purplish rash. Again, you can't be absolutely sure from the clinical signs what bug is causing this infection, and so you should start empirical antibiotics that cover all the likely pathogens. We'll talk about that. For special groups of patients, there are different pathogens, and while these first four pathogens apply to all patients, in young infants or children that are severely malnourished or children that are immunocompromised, then there's some other bacteria that can typically cause septic shock. And certainly Group B Streptococcus, where we see that more commonly in neonates, and E. coli is seen also more commonly in neonates. But both those, especially the E. coli and other gram-negative bacteria like Klebsiella, sometimes other gram-negative bacteria, are seen fairly commonly in children who've got severe malnutrition. So if you see a child with severe malnutrition who also has diarrhea, for example, then think that they might have gram-negative sepsis and treat them as such. I won't talk too much today about hospital-acquired infections, but there's broadly three types of hospital-acquired infections. Firstly, MRSA, methicillin-resistant Staph aureus. Secondly, the gram-negative bacteria that are producing is called ESBL, gram-negatives. They're quite common in hospitals now, but usually nosocomially acquired. And then there's another type of hospital-acquired infection called VRE, which is called vancomycin-resistant enterococcus. Again, I won't go into that today because they're hospital-acquired infections, but I do want you to know particularly about the common cause of community-acquired septic shock, sepsis and septic shock in older children, and also in special populations like young infants and severely malnourished patients and those who are immunocompromised as well. Often septic shock is associated with some preceding viral infection, and most of the septic shock we see, the child's been unwell with a virus. It could be influenza, it could be RSV or some other virus. They've been unwell with those respiratory viruses, and then they have like a biphasic illness where they have the virus and then they slowly may get a bit better, or they might just get much worse rather abruptly. Often it can be quite fulminant. The child develops within a 24-hour period, they get all those features that I've shown you before of much more severe pneumonia. And it's usually because they get a secondary bacterial infection on top of a virus. Many of these children have visited a primary care health centre or an emergency department, children's emergency department, in the preceding few days when they just had a virus or they just had a fever and they weren't that unwell, but then they get worse at home. So it's so important that we tell parents what to look out for so that they can be alert to a child who's not recovering normally from a virus, and that be alert to the fact that they might have septic shock or might have some other problem. Often, I think there's been delayed recognition of very serious bacterial infections, and that's why our mortality rates are very high, 50 to 70% mortality when a child finally is recognised as having severe septic shock. So I'm really trying to, I think we need to see if we can recognise it a bit earlier and take action earlier, because early interventions can really change the course of septic shock. They can turn it around, and our mortality rates from septic shock can fall. There is a concept in terms of giving emergency treatment called the golden hour. And I've talked about this before, but it's really important that we sort of understand what that means. And the golden hour are all the things that you need to do in the first hour after you see a child with septic shock, and after you all the things we need to do in the first hour, and clearly address the airway, the breathing, the circulation, conscious level, and get the right antibiotics into a child. So giving oxygen to maintain in a child with septic shock, usually we say, well, it's okay if their saturation is more than 90, but in a child with septic shock, it's important to aim a bit higher than that, because they've got a severe impairment of oxygen delivery to tissues. They might have low blood pressure, they've got low cardiac output, low oxygen delivery, and what we're trying to do is give them the most optimal oxygenation. So I think you give them oxygen, to get their saturation above 94%. That's close to normal. That's what you should be doing. Secondly, giving some IV access and getting to start with, if you can get a peripheral line in, that's usually sufficient. Take a blood culture, do a full blood examination, give a bolus of normal saline or Hartmann's solution, whatever you've got, and usually if it's moderate, then give 10 mils per kilo. If it's very severe, like the children I've shown you, then give 20 mils per kilo. Then the key thing is to reassess the situation after that, reassess their degree of shock after that. And very quickly, you need to start antibiotics. And as I said, the ideal thing is to start empiric broad spectrum antibiotics to cover all likely pathogens. You get one chance to cover all the bugs that might be causing this child's septic shock, and you should do it straight away. So ideally, a broad spectrum antibiotics that will cover those 4 bugs that I've mentioned group A strep, pneumococcus, Neisseria meningitis, and Staph aureus. You need to give antibiotics that cover all those 4 bugs. And there's several combinations of antibiotics that'll do that. So ceftriaxone and flucloxacillin will do that. And then to cover MRSA, if you think that's a risk, then using vancomycin or clindamycin will usually do it. Or you could give ceftriaxone and vancomycin, or you could give flucloxacillin, gentamicin, clindamycin, or vancomycin. Not all 4, but 3 of those: fluclox, gentamicin, clindamycin. Especially if you've got a child who's got likely MRSA, they're the options that you can start with. They will cover gram-negatives well. They'll cover the gram-positives well. They'll cover MRSA quite well. And I think that in children that we see with septic shock, we probably should be starting with that, a regime that's like that. And then of course, taking a blood culture and then scaling back antibiotics when something grows. Because if a child's got group A streptococcus, then you can just change back to just ceftriaxone or just penicillin. If they've got pneumococcus, you can carry on with ceftriaxone alone. If they've got Staph aureus, you can keep going with flucloxacillin if it's MSSA, or you can keep going with vancomycin if it's MRSA. And if it's Neisseria meningitis, then almost all of them are sensitive to penicillin, so you can just change to penicillin. The point is to start broad and then narrow the spectrum as you get a blood culture, if you do get a blood culture. But it's not starting broad, I think, that leads some patients to get progression of their septic shock because they've just been given a narrow spectrum antibiotic to begin with, and yet what they need is more broad cover. In children with septic shock, I think it's important to support them systemically, not just the antibiotics, but also support them systemically. And I tend to, in a child, when I see them early on, give some steroids. It doesn't really matter if you've got hydrocortisone or methylprednisolone or IV dexamethasone, but give one of those steroids IV, and ideally give it at the same time as you give the antibiotics. And the reason for that is because when you give antibiotics to children with septic shock, there's often what we call bacterial lysis quite quickly. That is, the bacteria that are circulating in the blood become lysed or broken down by the bacteria, and that can lead to an increase in the inflammation. And steroids can help dampen it down. So there are value in giving steroids, especially if you give them at the time you're giving the antibiotics. So put in an IV, take a blood culture, give the antibiotics, give steroids all at the same time in the first golden hour, and then you'll have done the best thing you can for the patient. Whatever you do in all of these steps, you need to reassess the situation, reassess where the airway, breathing, circulation, conscious level. Keep reassessing the patient. When I see a patient with septic shock, always take blood for a cross-match. If a child has unresponsive septic shock, often they look very pale and they may not be anemic, but they look very pale. When you get the hemoglobin back, you can decide whether you transfuse the patient or not, but at least you've got blood cross-matching to give blood if you need to. And if they're unresponsive to the first couple of boluses of fluid, then usually blood is what they need, as well as some other things. And then turn your mind very much to source control. And you need to find what the source is. Think to yourself, where's the source of this child's sepsis? And it could be in the lungs, it could be an empyema, it could be in the gastrointestinal tract, it could be in the urine, in the kidneys, it could be an abscess somewhere, etc. Think about where the source is for the infection and see if you need to get better source control. This is a child who had severe septic shock, and you can see on the X-ray what's wrong with this child. This child's got a very large empyema, and this was the X-ray of the this is the X-ray. You can see a large whiteout of the left hemithorax, and here's a large pleural effusion on ultrasound. And this child really needs to have this drained. If a child's got septic shock and they've got a big empyema like this, then they need to have it drained. We get used to seeing children who've got large empyemas or large effusions from tuberculosis, for example, and those children aren't toxic or septic usually. They're surprisingly, they can surprisingly cope with their pleural effusion. But if a child's toxic or septic, then they've probably got Staph aureus empyema or a pneumococcal empyema or a group A strep empyema, one of those first three bacteria, and they need to have that drained for source control and for control of their shock. I've talked before about how to drain it. I'm not going to go through that in detail today, but the best way to drain it is with what's called a pigtail catheter. These catheters, you can see the pigtail catheter here. They can be inserted into the pleural cavity, but you can drain it with an IV cannula if you don't have a formal chest drain. This pleural effusion was just drained with an IV cannula, a large bore IV cannula that you put in the same way as you insert a pigtail catheter or even a chest drain. This is the formal way to do it with a pigtail catheter, which uses what's called a Seldinger technique. You put in the needle, you feed into the pleural cavity, aspirate some fluid, feed in a wire, take the needle out, feed the flexible catheter. It straightens out, and you feed that over the wire, and then you've got a good sized catheter within the pleural cavity, and you can aspirate as much as you like. On the other hand, if you haven't got that, then you can use a large bore IV cannula. In a child like I showed you, who was a older infant, you could just use a 16 gauge or an 18 gauge, probably 16 gauge IV cannula, and just leave the plastic in and drain out as much as you can. Usually, this is a relatively simple effusion, and you can get most of it out, and you can make the child so much better. It's good to have two people to help you do this. And sometimes people think they need an anesthetic to give the child an anesthetic. Don't do that unless a child's had an arrest. You can drain this just with some light sedation with some ketamine, but you do need someone who's skilled in how to do it, who knows how to put in a IV cannula through the ribs or a pigtail catheter, whatever you've got. And you need someone to support the airway and the breathing. That's simply simple as that. You need an oxygen, a bag and mask usually, and you need some low dose sedation. And I usually use ketamine, just 0.5 milligrams per kilogram. And that gives you about 10 minutes of operating time. And usually I give it one dose, and then the patient's relatively sedated. You put in some local anesthetic with lignocaine, 1 or 2%, and then you can insert the needle. And again, it could be just a 16 gauge IV cannula, and you can aspirate. Often it's good to put a 3-way tap on it, and you can aspirate the pus or the fluid. And usually what happens is the child gets much better after that. You can use an ultrasound to guide you, but if you've got an X-ray that looked like what I showed you before, you don't need to do that. I won't go through how to do it, but essentially you're using the mid-axillary line. Don't go too low because the liver's low on the right side. On the left side, the spleen is a bit lower. And don't go too high because the rib space gets very crowded. So go mid-axillary and not too low and not too high, usually in the nipple line. Again, I won't go through this, but the simple way to do it is just with a 16 gauge IV cannula, and as long as you've got clear evidence of an empyema beforehand, either with an X-ray, clinical features of stony dullness to percussion and absent breath sounds, etc., and you've got or you've got an ultrasound which shows you where it is. This is the way you position a patient to do that. They're on oxygen. You've got somebody who's up one end just helping you out with just watching their airway and their breathing, and then you insert it mid-axillary line, just at or just below the nipple line if on the right-hand side, and the same on the left-hand side. This was the empyema that was drained out of the first child I showed you, and you can see 400 mils of purulent empyema drained out. And after that, the child's so much better. Just their conscious level improved, their blood pressure improved from being low to being normal, and their peripheral pulses and pulse volume became much better. And you can do that with a patient just lightly sedated. Now, not all children will have their source in their lungs, and not all children will have an empyema. Sometimes it will be an abscess somewhere. You've got to think, where else could it be? Where else could the source be? So in the golden hour, you want to resuscitate. You want to, if a patient's got a empyema, then you want to be draining that, and then you should do another X-ray and an ultrasound. But again, not all children will have their source as pneumonia or an empyema. They may well have other things like an abscess somewhere or a bone and joint infection. This child on the left had a periorbital cellulitis as a source of this child's septic shock. You can see how swollen and red, inflamed his eye is. And this boy had MRSA osteomyelitis as a source of his septic shock. And you can see his left arm looks so much more swollen than his right arm. And he had both osteomyelitis and an infected thrombus in his brachial vein. And so whenever you see a child who's got like a swelling, remember I said you need to think, is it just cellulitis or is it osteomyelitis? Is it septic arthritis? Is it pyomyositis, or is it an infected thrombus? And this child had, you can see the shoulders swollen too, so he had septic arthritis and osteomyelitis and an infected thrombus in the right brachial vein. And so find the source and decide whether the child needs a surgical consult to manage the source, to drain any pus, to remove any dead tissue, etc., to control the severe sepsis. That's very important. If a child's anemic, if their hemoglobin is less than 8, if they've got severe sepsis or septic shock, then transfuse them. You don't need to wait until their hemoglobin is less than 5 or less than 4 or even less than 6. I think if they've got septic shock, if then transfuse less than a hemoglobin of 8. And as I said before, it's if a patient's needing fluid to maintain their blood pressure, 20 or 40 mils per kilo of fluid, it's a good idea to start some inotropes. And you can start adrenaline quite easily. Other inotropes, dopamine or noradrenaline, are also okay, but adrenaline's a pretty good inotrope, and we mostly have adrenaline available. And the doses you start are quite low to start with generally, and then scale up to try to achieve an adequate blood pressure in the child. So I usually start at 0.05 to 0.1 micrograms per kilogram per minute. And that might be a bit confusing, but I'll try to explain how to make it up so that it's okay in a peripheral line. Obviously, it's ideal if you've got a central line. If you're in an intensive care unit, maybe you can put in a central line, but in the early phases of management, you'll have a peripheral line probably, and you can put in a second peripheral line to run the adrenaline. And this is the way you do it. If you put 6 milligrams of adrenaline, so 6 vials of adrenaline in 1 liter of normal saline, and then you run it, if a child is a small child, less than 4 years of age, if you run it at 5 mils an hour, right? Remember that's an okay infusion rate for a child of less than 4 years of age, then you're giving them 0.04 micrograms per kilogram per minute. That's what you're giving them if they're a 12-kilo child. And that's a sort of average weight. If they're between 4 and 12 years of age, then run it at 10 mils an hour, right? And you're giving them a 20-kilo child, you're giving 0.05 micrograms per kilogram per minute. So it's a good starting dose. If the child's more than 12 years of age, then run it at 20 mils an hour. So your 40-kilo 12-year-old is getting at 0.04 micrograms per kilogram per minute. It is important. You can't do this with just by counting drops. You don't do it by counting drops, but you can do it if you've got an infusion pump. If you've got a syringe pump, it's even better. But most hospitals now have an infusion pump, and you can run this through like that. Remember, it's very important. You run it in a separate IV line. You make sure the IV line is really nicely patent. Don't run anything else with it, and don't ever bolus this fluid. You're running it as a separate bag of intravenous fluid that's running through an infusion pump that's running at those rates for those ages. Very, very important. And the other IV cannula, you can give antibiotics and other fluids if you need to give more bolus fluids or give blood, etc. But don't run those things concurrently. This needs a separate IV line. Then you always, as I said, need to reassess a patient, and you need to be monitoring all the time other things, as well as the airway, breathing, circulation, their conscious level, then monitor their urine output. And for most children with septic shock, once you've established an adequate blood pressure, I usually give them some frusemide because you want to maintain their urine output, and it will reduce their edema. You want to maintain their blood pressure in the high normal range. So, but still having them on some frusemide early, I think, can be very beneficial. I won't go through this, but often it's useful to give some bicarbonate to these patients. They often have an acidosis for lots of reasons, because of a metabolic acidosis, because of the shock. If you give them a blood transfusion, often that's cold blood, and it's acidic, an acidic sort of solution. If you're giving them normal saline, then that's also an acidic solution. So they'll often have a metabolic acidosis, and it's helpful to give some sodium bicarbonate. So I usually give two things: one, frusemide, and sodium bicarbonate. And if they've got sodium bicarbonate, does two things. One, it'll help correct their acidemia, their acidosis. Even if you can't measure their acid base or their blood gases, then I would give them that. Remember, we can infer acidosis by the way a patient's breathing, and we often see those children I showed you before. They had quite acidotic breathing. They were breathing fast. One with the last boy, or the middle boy, was breathing very deeply as well. So acidic breathing is important to recognize. You can usually infer that a child would have a severe metabolic acidosis, and you've given them bicarbonate. That can be helpful. Again, don't give that through a very good intravenous line. If you, again, give adrenaline through a line that's not very good, and they get extravasation of the bicarb of adrenaline, that can cause some tissue necrosis, and the same with bicarbonate. So you just have to be very careful and have very good intravenous lines in, or have a central line in if you need to. It's very good if you can measure blood lactate. Not every hospital can do that, but some hospitals are now starting to be able to do that. If you can measure blood lactate, and two things I think can be very helpful. One is to measure blood lactate, and the other one is to measure, if you can do blood gases, then measure a child's venous oxygen saturation, their venous saturation on a blood gas. And that's because a venous saturation tells you a lot about their heart function. If a patient's got a normal venous saturation, and our normal venous saturation is typically 70 to 75%, different to the arterial saturation, which is like 95 and above, isn't it? 99, 100. A venous saturation is usually about 70 to 75%. If it's less than 60, and certainly if it's less than 50, then that implies that their heart function is very poor. And in those patients, definitely you should start adrenaline. I start adrenaline fairly early in these patients at a low dose, like I showed you, 0.05 micrograms per kilogram per minute, and just have it in the background continuously. And you're aiming for a blood pressure that's the higher level of normal, not above normal, but high normal. So you can try to maintain their urine output, try to maintain their perfusion of their blood to their brain, etc., etc. Sometimes it's helpful also to give them, if they're poorly conscious, I generally, for 48 hours only, give them mannitol. And it's all you need to give is like 0.5 gram per kilogram twice a day for 48 hours. No more than that, because it can have consequences. But 48 hours is quite safe, and that will help protect against cerebral edema. And many of these patients have cerebral edema for lots of reasons. And if you give mannitol, it can help protect against cerebral edema. So I've tried to give you tried to explain how to look after patients with septic shock, not where you've got a big intensive care unit, but where you've got maybe a high dependency area or a small ICU that can manage patients just a little bit stepped up from what you can do on a general ward by running some adrenaline, by giving some furosemide, by giving some steroids, by adhering to the golden hour and trying to do all of the things that I've mentioned in the golden hour, and by getting source control. So in a acute pediatric ward, there are things that can be done. In a ICU and a pediatric ward, there are things that can be done as well. This is a femoral line. I won't go into how to put one in, but it's something that as trainees we should all of you need to learn about how to put in a femoral line. And again, if you've got ultrasound, learning the use of ultrasound to put in a femoral line or an internal jugular central line is important. I wanted to just say how much basic investigations can tell us about a patient with septic shock. And these investigations that I've just put up here, they're available in not all hospitals, but in many hospitals. And if you have access to blood gases or electrolytes, you can say a lot about this patient based on the blood gas. So this child has, I want you to look at it carefully, this child has a severe metabolic acidosis with a pH that's low. The child is compensating somewhat for that by breathing fast and blowing off carbon dioxide, so the carbon dioxide level is low. The very low bicarbonate tells you the child's got a metabolic acidosis, and the base excess or the base deficit being very negative tells you that there's a severe metabolic acidosis. The lactate that I mentioned is high, so that's that often occurs in children that have got poor oxygen delivery to tissues, because if your tissues, your cells are not receiving enough oxygen, then they anaerobically metabolize and they produce more lactate. That's the source of lactate predominantly in septic shock. The child's got hyponatremia, so the sodium level is low, and you can see the creatinine and urea are high. So these are basic investigations. Not everyone can do them, but if you can do them, then you need to be able to interpret them as optimally. Most hospitals can do full blood counts, and when you look at a full blood count, you can see this child's anemic. Their white cell count is not high, but when you look at the differential, it tells the whole story. Their lymphocyte count is low, their neutrophil count's low normal, but their band count is high, and the metamyelocytes and myelocytes are also elevated. They're present in the system, which means that the bone marrow is working very overtime. It's working in response to an infection, and this is the typical full blood examination or full blood count of a child who's got septic shock. Sometimes the white cell count will be very high, and sometimes it'll be very low, and sometimes it'll be normal. But look at the differential and see how much they've got immature forms of white cells, myelocytes, metamyelocytes, band forms, and it's if they've got lots of those, then that looks like a toxic blood film with a big left shift. I think some of the labs are reporting whether there's a left shift in the blood picture, and that's what a left shift really means. Shifted to the left of the immature forms. This child's got a low platelet count, and that's fairly typical with septic shock as well. And the child's got a high INR, and a coagulopathy can be common in children with septic shock. Now, you might not have access to all of these investigations, but for those that you do, those investigations you do have access to, it is really important that we make the most of them and interpret them in the most detailed way. I just want you to be able to do that. I just wanted to say a couple of other things. WHO has a guideline on the management of shock in children, and it covers septic shock and also other things. But it says a really important thing, that after in many hospitals, we often see children getting 20 mils per kilo plus another 20 mils per kilo and another 20 mils per kilo. No, that's wrong. If a child needs like 40 mils per kilo of fluid and they still have signs of shock, then those children need to have an additional response, not just more and more and more fluid, because they'll just end up being edematous. they might need like some adrenaline, or they might need more fluid, or they might need less fluid. They might, instead of giving them more fluid, they might need less fluid, and they might need some adrenaline. They certainly need consideration of source control, like where is the source of this sepsis? And they need to have that dealt with promptly. It's no good to write a referral to orthopedics or the surgeons and have them, come in 2 days' time. You need someone to come and see the child now and to decide on a plan of management that involves having adequate source control. If indeed the child needs surgery, they won't always need surgery. Sometimes you can deal with the source control yourself by draining an abscess or draining an empyema. They often, if they're very severe, will need a blood transfusion, so cross-match always. They often will need diuretics or mannitol, like I said, furosemide or mannitol. They sometimes will need positive pressure respiratory support, and that might be as simple as using high-flow oxygen or using CPAP. We talked about high-flow oxygen in the last couple of weeks, high-flow oxygen therapy. It's important, it's coming in, and you'll be... we'll teach more about that soon. They might need hydrocortisone or a steroid. That's important. If they're malnourished, they might need multivitamins, because sometimes that can cause like a septic shock picture if they're thiamine deficient or they're vitamin C deficient. So giving those to children who've got malnutrition and septic shock is quite important. And they might need an echo to assess their heart function or exclude tamponade, or they might need to have a central line put in, and that might require the adult intensive care doctors or anaesthetists to come and do that, or you might develop the skills to do that. The point is to have a differentiated response, not just giving more and more fluid and giving some antibiotics. You need to have a more holistic response to this child's septic shock. Okay, that's all I want to discuss today, and I think I might leave it at that. There are many other things besides septic shock that can cause a patient to be in shock, but I think we'll leave it at that today, and just we'll talk about other forms of shock at another time. But I really wanted you to be recognizing patients who've got severe systemic sepsis and the early stages of septic shock, so that we don't continue to have mortality rates of 50 to 70% or even higher. Sometimes it's higher, and we can start recognizing and holistically treating these patients a little bit earlier. And that's all I want to say today about severe sepsis and septic shock. And I hope that's been somewhat useful for you. And I'm happy to answer any questions that you might have. I hope the recording's been better this week, and I will upload this onto YouTube at some stage. And as I said, I will record the last week's talk again at some stage. I'm going to stop the recording now, and I'm happy to answer any questions that you might have. Thanks.